Welcome. I'm Nikki Young, Program Manager with the Child Neurology Foundation. Today's talk is part of our ongoing series bringing together caregivers and health professionals to provide expert advice to the child neurology community. Each topic focuses on what we heard from our partners and our families as a top priority. Today, we are discussing the next steps when genetic testing doesn't give you answers, how providers and families can continue to have hope.
So first, I'd like to thank our education series partners. Without them, this wouldn't be possible. We appreciate your support.
I'm joined today by Dr. Heather Mefford with St. Jude Children's Research Hospital and Richard and Judy Poulin here to share their experiences. Welcome and thanks for joining me today.
Thank you, Nikki. It's great to be here and contribute to this seminar series. So my name's Heather Mefford, as Nikki said. I'm a pediatric geneticist and physician scientist at St. Jude Children's Research Hospital. I came here recently to join St. Jude's effort to expand their focus to pediatric neurologic disease research. My research background is in gene discovery and identifying genes for pediatric neurologic conditions so that we can do a better job of diagnosing families and also identifying new targets for novel therapies. So as a geneticist over the past 10 years or so, there's been an incredible advance in our ability to diagnose children and provide a genetic diagnosis when they come to our clinic. But we're still not anywhere near 100%. So what I want to focus on today is what are our testing options in kids with neurologic conditions who present in childhood? What are the testing options? How do we think about which tests to do? What does the diagnostic odyssey look like? And in those cases where you go on a diagnostic journey, but don't end up with a diagnosis, what do you do next? So the first thing I always like to think about is why is getting a genetic diagnosis important? And I think most families who've gone through this process are aware, as well as physicians. But just to give you an idea, what I think about when providing a diagnosis or testing options for family is that if we're able to provide a genetic diagnosis, we can do a better job of counseling families about the prognosis for their child. So what will my child's life look like? We can talk about recurrence risk, meaning if you have another child, what's the chance that they will be affected by the same condition? In some cases, and this is certainly true in pediatric epilepsies, where most of my research is. In some cases, having a genetic diagnosis will affect how we treat the disease, which some will be able to determine whether there are some medicines that make the disease worse or some medicines that might make the disease better. Importantly, I think this provides research opportunities for families, both to participate in how do we understand more about the disorder itself, if it's a new disorder, and down the road, perhaps research opportunities for clinical trials. Families, as I'm sure many of you are aware, if you have a genetic diagnosis, many families connect with others around the world by going online, Facebook groups, family foundations, other families with the same diagnosis, and this provides a lot of comfort and support and guidance. And the long-term goal, really, and why I do what I do in the gene discovery space, is that we want to identify new targets for therapies. And we have a lot of new therapies coming down the road right now, which is very exciting, including gene therapy and other similar approaches. And understanding the genetic causes of disease allows us to be more precise about developing those therapies. So we have a lot of options for genetic testing, as I said, in the pediatric neurology space. And some of these you may have heard of, but I'll just give a brief overview. One of the first kind of new big tests that came onto the scene over 10 years ago now is called the chromosome microarray or chromosome array. This is an approach that allowed us to find small missing or extra pieces of DNA, which we know cause a significant fraction of pediatric neurodevelopmental disorders. The next testing option that came on the scene is our sequencing approaches. In the past 10 years, the new sequencing approaches that are much more efficient have come online that allow us to sequence not just one gene at a time, but many genes at a time. This is a gene panel. So for example, if your child has epilepsy, there are options for epilepsy gene panels that have dozens to hundreds to even thousands of genes that we test at once, looking for a small sequence change or spelling error rather than missing or extra chunks of DNA. And then the most comprehensive test we have right now that is widely available clinically is exome sequencing. This allows us to sequence all 20,000 genes in the human genome and look for spelling changes in any one of those genes. Whole genome sequencing is even more comprehensive. It allows us to sequence 100% of the DNA, not just the genes. It's not as widely available clinically. And when we do that test, although we sequence 100% of the DNA, we still really focus on those that 1% of DNA that that codes for genes. And then finally, there's a test called RNA sequencing. This looks at when we go from DNA to RNA to protein. RNA sequencing is used in very special cases right now, where we want to help interpret a finding that we may have found in the exome or the genome. And it's not, it is a more of a confirmatory test than a discovery or diagnostic test at this point. So with all these options, how do we decide which test to do? Well, I think some of the things we think about is which test is most likely to give us a diagnosis. For chromosome arrays, depending on the disorder, you can get a diagnosis in maybe 5 to up to 30% of kids. This depends on whether they are on which class of disease they have, whether it's a developmental delay, a specific type of epilepsy, a muscular dystrophy. The range the diagnostic range will change. Gene sequencing tests are overall a higher yield. Gene panel will give us a diagnosis in up to 20 to 30% of kids. And exome sequencing, which again looks at all 20,000 genes and is a fairly unbiased test, we can get a diagnosis in 25 to 50% of kids, again, depending on exactly what the disorder is. But I like to point out that, in whole genome sequencing and RNA sequencing, we don't have enough data. Whole genome sequencing should be as good, if not better, than exome sequencing. But I'd like to point out that even with exome or whole genome sequencing, we really only get up to about 50% of kids where we're able to provide a genetic diagnosis. This is just the data for early onset epilepsies, which is what I study. And if we look at the diagnostic yield, exome is better than a gene panel, which is better than a chromosome array. So if money, insurance, availability was not a consideration, you would absolutely start with an exome because that's your best bet for getting a diagnosis. In reality, we often start with a gene panel, and in some cases even start with an array, depending on the situation. So all of these tests mean that kids get different first test, second test, third test. And so what we talk about is the diagnostic odyssey can take many different forms. And often it feels like a never-ending cycle, trying to chase a diagnosis. And sometimes we never get there. So I'm going to tell you about two examples of kids. These are based on kids that I've actually seen of diagnostic odysseys. This first little boy presented around 6 months of age with some developmental delays. Then he had seizures. He had lots of testing, starting with actually an array. And I'm showing you here the chromosomes, which is representative of the array. And it actually showed an extra chromosome Y. But as a geneticist and understanding what an extra Y chromosome means, I didn't feel that it explained what was going on. So because of the seizures, we sent a gene panel. We looked at 327 genes at once. And it came back with 3 variants of uncertain significance, which I'll talk about what that means in a minute, but basically it was uncertainty. So we said, well, let's test the parents. All of these were inherited. The parents were healthy. And our interpretation was that none of these genetic changes were causative and explained what was going on. So after more than 20 months and a huge array of tests, we still had no diagnosis. The second example is another young boy who presented with developmental delays. He also had infantile spasms, a type of seizures. And here again, we had a series of tests over several years, actually. So started with a gene panel. We moved on to exome sequencing, which was just becoming available at the time we sent it, because he was not getting better, he was actually getting worse. This exome testing again gave us some genetic changes, but we didn't really know how to interpret them. So we sent the same test for the parents. And we actually found that one of the genetic changes was a new change in the child who was affected and was not present in either parent. So this was suspicious, but it wasn't in the known disease gene. So we really didn't know what it meant. And unfortunately, he passed away. And at the time he passed away, the diagnosis was still uncertain at best. So when we do these genetic tests, I think I just want to give you an overview of the kind of things that the laboratory or the physician has to think about when we get back a genetic change in a child. This is a very busy slide. It's intended to be. This was early days of interpreting variants from exome sequencing. And the point is, it's complicated. But overall, we take several things into consideration when we look at a genetic variant and ask, could this be causing disease? And those three things here I've identified as the function. So what's the effect of that genetic change, the frequency, and the family structure. So when we talk about function, we ask, does the genetic change that we found look like it's actually going to cause a problem, right? So genes code for proteins, which actually do the work and are the building blocks in our body. So we asked, does that genetic change look like it's going to affect how the protein is formed or how the protein works, or will it cause the protein not even to be made? And there are many different ways to do this. We're pretty good at predicting, or at least interpreting what the change will be. And we're getting better at predicting whether that will be a good change, a bad change, or not make any difference at all. When we talk about frequency, the question there is, if we find a genetic change in a child with a very, very severe neurologic condition, and then we go look at 100 people in the population, we find that 10 of those healthy individuals have the same genetic change, it's probably not causing the disease in that child. So again, for very severe diseases that we expect to be, many of them are caused by new changes and not present in either parent and not present in the population. So we take that into account. We'll hear a little bit later about rare recessive conditions. So recessive conditions occur when each parent has a genetic change, but they both, when they come together, so there are two genetic changes in the child, it causes disease. So in this case, we expect to find the variant in the population, but it should still be very rare. And then finally, what's the family structure? And there are lots of publicly available free data now on frequency of genetic changes in the population. So finally, when we think about the family, we want to ask, does the variant look like it tracks in the family in the way that we expect? So again, is this X-linked? So does it affect only boys and on the X chromosome in unaffected moms? Is it, do we have other affected family members that we can test? For example, if it's a milder disease and the child and the father are both affected, we expect to find the same change in the child and the father. So these are all kinds of things that we have to consider when we are deciding if a variant is causing disease. And sometimes this is why it takes so long to get your test results back. So the interpretation of the variant, like I said, takes all these things into account, and then you get a test report back. And many of you may have had a test report that says, we found a change, but we think it's benign, so not disease causing. Many changes are variants of uncertain clinical significance. These are extremely frustrating for both families and physicians, because that means that we found something, but we don't exactly know how to interpret it. We don't know if it's causing disease or not. And I would caution you that if you have a variant of uncertain significance, this is not a diagnosis. And in fact, the majority of variants of uncertain significance, once we accumulate more data, actually turn out to be not disease causing. And then finally, you could get a variant back that's pathogenic or likely pathogenic, meaning likely to be causing disease. And then the interpretation of the test then is either you've had a negative test. So next slide, Nikki. So these benign or uncertain tests are non-diagnostic or negative. When you get something back that's pathogenic or likely pathogenic, we consider this diagnostic or positive test. So as I said, these diagnostic odysseys, of course, can take many forms. But what do you do when you get to what seems like the end of that odyssey and you don't have a genetic diagnosis? Why does that happen? Next slide. So there are several different reasons that this could happen. It could be that the disease is actually not genetic. I don't like to say that as a geneticist, but it is true that there are disorders out there that are not genetic. It's certainly possible that the gene that's causing the disease wasn't actually tested. So if you don't look for the right cause, you're not going to find it. And then there are several other reasons. Either sometimes it's a new disorder, we haven't actually found the gene for it, so we're not testing it, or we can't interpret the variant. There are technical reasons that we miss things. I'll get to that at the end. And then the variant might be misinterpreted for various reasons. So we might call it benign and then get more information later and call it pathogenic, or vice versa. So when we get to this point and you don't have a diagnosis or everything is still quite uncertain, is this the end of the line? And I think the answer is no. So for both physicians and for families, I think that you should think of this as a speed bump or a yield sign, where we've done everything we can do, but we've gotten to the end of the line and trying to figure out where to go next. And there are options. So next slide, Nikki. So think of this as a speed bump. And the next few slides, I'll just talk about some of the things that both families and physicians can think about and how to move forward. So next. When you get to the end and you really have no diagnosis, I think as families, stay in touch with your geneticist. And if you have not engaged with a geneticist, connect with one. So sometimes these tests are done by specialists who are caring for the child, but engaging a geneticist who can follow up long-term and advise you about new tests that are available is very important. And this can be a genetic physician or a genetic counselor, or ideally both. We tend to follow patients on about every year or two. It's not fast. We used to say come back in 3 to 5 years and we'll see if there are new tests available, but the pace that genetics is moving, now it might be 6 months to a year. We can look at your test results and say, hey, should we have this reanalyzed? Because every month we get new information about new disease genes. Are there new tests available that might be better than the one that you had? And this is certainly true for patients who were tested a decade ago. And it can be true for patients who were even tested just several years ago. And as I said, even if you've had an exome, you can ask for reanalysis. When we're uncertain about a finding, so a variant of uncertain significance, it might be in a gene that we don't know if it's a disease gene. I encourage both physicians and families to find the experts. So is there anyone studying this disease or this gene that might be able to look at the variant and say, we think this is actually potentially disease causing, or we've seen this before and it doesn't affect the gene at all, so you should ignore it. There are also matchmaking databases available for clinicians that allow you to put in a gene and ask, is there anyone else out there who's interested in this gene or have patients with changes in this gene? And on the research side, we've used this extensively to identify new disease genes. And then if there is someone studying the gene or the disease, consider enrolling in research if they have a research program available. Next. So just to end with how these diagnostic odysseys played out. So here, after 20 months, we had no diagnosis. But we saw the patient back and said there's this new test available that that sequences all 20,000 genes. This was whole exome sequencing. And this actually provided a diagnosis for this child. So he had a new change in a gene called MEF2C. And by the time the family came back to talk about the results in clinic, they'd already connected with a family group online, which was fantastic. I was a little bit confused because I said, well, I know that MEF2C is an epilepsy gene, and we did this 327 gene panel. But when we went back and looked at the test that was done and talked to the company, MEF2C was not on the test that we sent, and it was added just probably 2 to 3 months after we sent the test. So if we'd waited, we may have gotten an answer from that first gene panel test. But this is the way that things evolve very quickly, and tests can change. Next. In the second example, we had an uncertain diagnosis in this young boy who passed away at 4 years of age. And in the meantime, he had a younger brother who was born and started to show some of the same signs that his older brother had. So we said, well, it was milder than his brother, but we said, well, this is most likely it's the same thing. But we didn't get an answer a couple of years ago. Despite that, I said, you know what, let's just send an exome on this kid. It's 2 years later, we have more knowledge, and we have a family structure now that changes what we think about the inheritance of the disease in this family. And that came back with a diagnosis. The diagnosis was for a recessive disease called Tango 2. And when they went back and looked at the older brother's exome data, they said, yep, he's got the same thing. But why didn't they diagnose it when we did the test in 2014? Well, there were two reasons. The first is that this disease was not even described until 2016, which is the same, just months before we did the test in the younger brother. And the second reason is that one of the genetic changes was a change that they didn't look for on the exome in 2014, but by 2016, they were able to identify that change. So we had both new knowledge and new technology or analysis techniques that allowed us to find genetic changes that were causative. Next slide. So these were long diagnostic odysseys for these families, and I'm sure many of you have been through that. Our goal is really to shorten that diagnostic odyssey. So to go from first having symptoms to a diagnosis, we want to shorten that time frame, and we are definitely getting better at that. Because we want to be able to implement some of the targeted therapies that are being developed. Ideally, we'd like to know about it even before the onset of symptoms. This is more difficult and requires things like newborn screening, right? It's okay, go next slide, Nikki. But that's the long-term goal. And so I think, early diagnosis we know is important for many reasons. Even so that you can just start early, physical therapy and developmental therapies that we know make a difference. We encourage physicians to start with your highest yield test because that's most likely to give a diagnosis if that's possible. And I think, whole genome sequencing is the closest thing we're going to have to one-stop shopping for now as far as a test. It's becoming increasingly available, but even whole genome sequencing is not perfect and doesn't get us anywhere near 100% for diagnoses. And that's why we can continue to do the research that we do. And in the future, we may even get to the point where we're doing this in newborns, or at least doing newborn testing that might give us a glimpse into being able to do early treatment. So I'm going to stop there with that part of the presentation. I hope that was helpful and gave you a nice overview of kind of the complexities of genetic testing. And then we have a family here today who has had their own diagnostic odyssey. This is Richard and Judy, who have a young daughter who's gone through a diagnostic odyssey. Welcome. And we're hoping to hear a little bit from the family perspective and have a conversation about what that's like from the family side, right? And how we can all work together in the future to make this a more efficient process. So Richard and Judy, I guess it would be great if you guys could just start and tell us a little bit about your story and kind of where it all started for you.
Sure, yeah. So my name's Richard and this is Judy, and we're Riley Ann's parents. And when Riley was about 3 months old, we started noticing her doing weird movements with her eyes and limbs. We were new parents, so we didn't want to be overly worried, but we were worried. we went to the regularly scheduled checkups and we mentioned what we were seeing to the doctor. But when we went in with the doctor at that time, she was just healthy. She wasn't showing symptoms at that time. It was still early on in what was going on with her. So all we had left to do was just kind of document what we were seeing at home.
And I took notes on everything. We saw other doctors and shared our notes. But again, no one seemed to be concerned as they did not see what we saw. But there's this one night where her eye movements went on for a really long time, for about 10 minutes. Then we went to the ER.
Yeah, and it was raining. I remember that night. And when we arrived, the movements had ended by the time we got there. But we were telling the nurse at the ER what we saw. And at that time, we were saying it was going on for about 10 minutes. And from her perspective, that was an emergency. So they administered diazepam. They wanted to put her on an EEG with 24-hour surveillance. And immediately they were running tests. I'm sure they had an idea in their mind. We weren't really too sure at that time, but they were taking blood, urine, cerebral spinal fluid. And by the time we were there for a few days, there wasn't anything that they could tell us. And we were advocating that we needed to get out of the hospital because it wasn't good for any of us. And they discharged us with no answers.
But they did say that it was epilepsy and it was a seizure. So they call it the seizure, but we call it the spell. But it continued to happen every 3 days. And I tried to explain to the neurologist that it's happening. But the doctor said seizures don't work like that. So we were prescribed a medication that was for seizure.
Yeah, and the medication had horrible side effects. And everything was based on what everyone could see. So I don't fault anyone's, any of the doctors, don't fault any of them. But when she was taking this medication, she was knocked out. And when I remember holding her, and it was just this awful feeling. It's just, it's lifeless. And so, as a parent, obviously I'm concerned, Judy's concerned. So I began researching what's this epilepsies? What are the different types of epilepsy? And nothing really matched what we were seeing at home. And we started going out to other doctors to get other opinions. We even flew to other countries searching for answers. At the time, we were in Singapore and we had flown to Thailand trying to get some answers. We also did genetic testing twice based on the doctor's recommendations. And they had an idea in their mind. So they were recommending the panels to us. I didn't really understand it at the time. So we did the panels that they had recommended, and they came back inconclusive. And no answers ever came at that time. But we knew to get rid of those medications. And the doctors had different ideas of maybe what it was every time we went to go see a different doctor. So we had heard dystonia, CP, and then some sort of unclassified epilepsy. However, based on what we saw, it never fit any of the descriptions.
One time we were able to get the spell on EEG because we asked the technician to stay late. And we knew that day it would happen. Just like clockwork, Riley had her spell. For a moment, we had like a sigh of relief because it came back normal. But we've done every test possible, but we still didn't have any answers. So I kept taking notes, and Rich continued to search for answers.
Yeah, it sounds very frustrating, and I hear you. And it's hard when you feel like that maybe people aren't hearing what you're saying, right, about your child. I try to remind myself that parents are usually right, but sometimes it's hard, right? And especially when it's your first child, and we kind of expect most kids to be normal and most first parents to be a little bit jittery. And but I think it's important, right? And it sounds like clearly you were doing a good job advocating for Riley. And I guess it'd be great to hear a little bit more about, what else did you do to advocate for her during this process before you had a diagnosis?
Yeah, and I would say Judy was really good about this. She was always talking with other doctors. And she's not a shy person anyways, but obviously when it came to her daughter, she was very proactive in going to the doctors, trying to get clarity when she didn't understand something. And then she would pool all this information together. For my part, I would continue to do research online. And Dr. Mefford, you kind of spoke earlier about going to search for doctors that maybe had a specialty or a little bit more experience in a different area. And so together we just tried to contact doctors and remain steadfast in that we wanted to find the answer. However, during this time, Riley was still having, issues, and we didn't understand what was causing it. But every time we went to the ICU, Judy would explain everything that we knew, and she would try to share her notes. And eventually, I had found this research paper about an ultra rare disease called AADC. And I initially dismissed it because I remember in one line it said 130 people in the world had this disease. And so I was like, no, we got a healthy family. This is not us,
Yeah. But then later, my brother saw an article on Facebook about a Taiwanese girl who had this rare disorder. So I started telling him about it, and he didn't think it was AEDC until I told him that, 80% of the cases are from Taiwan, and which is where my parents are from.
Yeah. And so getting family involved, I would say, was a godsend for us because, I'm hyper focused and I kind of dismiss some things that I shouldn't have, that I didn't see. And after I heard that, immediately, Judy's younger brother was living in Taiwan. So I was like, this is the doctor we need to talk to, because I found a research paper that he had published. I'm like, could you please get us an appointment with this doctor? And this is just before Christmas. So, I'm like, this isn't going to happen. But amazingly, he was able to get that appointment. And by the end of the week, we were flying to see him in Taiwan. So he was able to give a diagnosis for our daughter just by observing her, because again, he was the most experienced in the world as far as I know. But they had done a couple of diagnostic testing to just confirm this, which was the cerebral spinal fluid, and back to the genetic testing, which was, the 100% diagnosis that they needed for us to say that, yes, 100% it was AADC. So, and that genetic test gave us a lot of information. One of the things that I think you could compare it to the genetic testing that people are doing that want to find out about their family history. That genetic testing gave us that. I mean, I knew the phenotype, I knew which chromosome it was on, and then we could even see where that gene was prevalent. So obviously Judy's was prevalent in the Southeast Asia region, and mine was from European region.
Mm-hmm. That's quite a story. That's be wonderful advocates for your daughter. So that's great. It's also a bit unusual. So I think, not every family could do this. And I think the support you had from your family and the people around you clearly was helpful as well. But continuing to push for answers got you there. I'll also comment just based on kind of what I was saying earlier about testing, right? So I think it sounds early on like the physicians were focused on what they thought were seizures in Riley, and that's what directed the testing, right? And the testing was gene panel, which obviously was looking at the wrong genes for the disorder that she had. And had she had exome sequencing at the start, you may have had a diagnosis earlier, right?
Exactly.
So just a comment about, again, we kind of test for what we think is happening, and sometimes we're not always right. So good job for continuing down that path. So, you're one of the lucky families who got a diagnosis, and how has having that diagnosis now impacted, Riley's care?
Yeah, so I would say just having that answer gave us a little bit more of indication on what we were going to do as far as a treatment plan. We did learn about some medications and supplements that we could probably do with our daughter, but none of them worked. So what we were able to do was concentrate on making our daughter comfortable, understanding what her potential complications were, and then also what we could do to maybe kind of support her in that. But one thing we did learn was that she wasn't having seizures, which is why the EEG came back normal. She has a thing called ocular gyrate crisis. And strangely enough, this happens every 3 days, just like clockwork. So the doctor was right. That's not how seizures work, but this is how ocular gyrate crisis work. So we were reassured that, okay, this isn't a seizure. We could go out, we could do activities, we could support her. But at the end of the day, we had an answer, and early intervention is key.
Yeah, we also learned some life-saving tips about feeding, digestions, and sleep positions. It was hard for Riley to eat, so we always had to keep her upright. And sleeping was also hard. We took turns to carry her because she had to be in upright position. And there was other important complications that could be fatal that we were not aware about previously, but now that we know. And we were concentrating on other issues and that did not even apply to our daughter. So as a parent, as all parents will agree, we know our children best. By not giving up, we got the right care and we need it for our daughter.
That's great. And so have you been able to connect with other families with the same or similar diagnosis, and how has that helped?
Yeah, it was a wonderful feeling. Parents who already experienced everything we did and other parents who were in the same situation as us. So we immediately connected with them and all over the world thanks to social networks.
Yeah. And our community is small. So we really depend on each other. Even if you have a large community, I think you're going to have even a lot more support. But with the small numbers, we had a lot of strength between each other. We were recommending resources, news, what worked, what didn't work. So I really appreciated having other people that had been down the same journey. And it was just so unique that they could say, yeah, that happened to us too. Oh, we did this too. And you just felt reassured. Okay, we're doing things right. Okay, this is kind of a similar pathway that others have been down. We're not behind. We still have a lot that we can do. And Judy and I are both teachers. So we thought that we could get back to the community with educational activities, ways that you could support cognitive development with our children.
That's great. I always encourage families with a new diagnosis, if they're comfortable, to reach out and see if they can find that community as well, because I think those benefits are, from other families going through the same experience, are things that you can't always get from a physician or a genetic counselor or anyone in the profession. You have to really have boots on the ground and know what you're dealing with, and that practical experience is invaluable. So as you were going through your odyssey, I think it would be helpful for me and any other physicians listening, like what was most helpful for you?
I would say we went through several doctors, but our main neurologist in Singapore, she explained everything to us in layman's term. You kind of touched on it too, Dr. Mefford, that we don't always know the diagnosis, and it's a journey, and that journey is not a linear line. And our doctor kind of gave us a similar message, and I really appreciated that, because before it was like I felt like we had to kind of push for something instead of, hey, let's figure this out together. And when our doctor was explaining things to us, she was a little bit clearer that we have to kind of figure this out together. We'll give information to each other, and it may not be a straight line. We may not always get the right answers, and that's okay. That's not a stopping point. As you said, it's a speed bump.
For me, it was about uncertainty of the medication, because we had such horrible experience with the early medications we were taking. I'm always worried about the medication she's taking. But it's great for the doctor to explain what the medication was and how it was going to help our daughter and what the side effects are. So I feel better and more confident in what we are doing.
Good. Yeah, communication, a clear communication, honest communication, I think is key. So that's great that you found a provider that would work with you in that way. This having an affected child and going through a diagnostic odyssey like this can be very difficult, right? So can you share with other families kind of how has this impacted you, either positively or negatively, and what advice would you give to families as you go through this kind of uncertain and sometimes scary process?
Yeah, definitely scary. And strangely enough, I always talk about it to the other parents that we meet inside of different communities, is that we had everything planned, and it's so strange to think about it in hindsight, but we were married, we had stable jobs, we had the ideal location, but we didn't expect a child with challenges, and I don't think anyone does. But I would say being on our feet and having each other, that stable situation, thankfully we had it, because it would have been near impossible to do what we did.
Yeah, and I feel that our family and friends were always so supportive. Eventually, we gave up our jobs and searched for new jobs so that we could be closer to family. And we both work as a team. Everything is about her now. Uh, so, to creating balanced schedule to support each other and to help us provide better for our family.
Yeah, and I would just add that having an understanding and supportive employer was very useful for us, because we had to give up our jobs. And then when we were coming to our new jobs, we had to be very honest in what we could do. And, we had to leave work at this time and what we needed for our daughter. So we found an employer that understood this. And even though we had to make a little bit of sacrifices with our professional, goals and where we wanted to work, it was well worth it. So, sometimes you have to evaluate the whole picture when you're thinking about jobs and what you're going to do for work or for your family. But in the end, when we thought about Riley first, it all worked out.
Great. Yeah, I think it's really important to have a support system, whether it's your family or your friends, your colleagues. And sometimes it can take a little bit of time to explain to them, kind of what you're going through. And if they don't understand it at first, it can be hard. But if you find that right support system, I think that's hugely important to help you get through this. And it's great that you had such a solid relationship and really work as a team and can support each other through that. So last question, I guess, is there anything, that you wish you'd done in hindsight? To me, it sounds like you did everything right. But what changes would you make, or what advice would you give to families who are just starting this diagnostic journey?
Yeah, I know we're our own worst enemies, but I definitely remember that, because we planned having Riley, well before she was ever born. We planned it. And I remember the doctor asking us, do you want to have a genetic testing or a genetic screening? I forget what they called it, for any potential issues. And I'm like, no, we got our whole family is healthy. There's no issues. And I kind of, was saying, Judy, the doctor's trying to upsell us on this. And I look at it now, and I should have not done that. And who knows if that genetic testing would have showed that there was that potential of having this ultra rare disease. But as you said, Dr. Mefford, genetic testing's enhancing so much. I know that gene panel now exists for us and that it's just growing. So I would 100% do a genetic testing before having a child, just to even see what are the potential things that may not be aware, because we were autosomal recessive carriers for this gene that we didn't even know about. And, that could happen to anyone, but it's ultra rare that would happen to most people. But again, just having that genetic testing to reassure you and just have a little bit more information.
Yeah. So even if you don't have a family history, I think it's really important to have genetic testing before you have a family because of this factor as well. Try looking other gene panels. It can totally blindside a family, which is something that is echoed by all in our small community.
Yeah, it's hard with ultra rare diseases for sure. And, there are other conditions that kind of come out of the blue, as we would say, that is a new mutation and that you can't test for. So I think every family's different, but knowing kind of what your threshold is for how much information you want and how to use that information is really important. And I think having those conversations with your partner too about what are we going to do with this information, how will we use it, and with your, also with your physician. But that's great. So thank you so much for sharing your journey. I think it's so important, and I'm going to turn it back over to Nikki.
Yeah.
Thank you.
Thank you all so much for joining us today and sharing your expertise with the child neurology community. Really appreciate all your time and sharing all your wonderful knowledge. For those listening, if you'd like more resources, please check out our website at childneurologyfoundation.org. And if you have any additional questions for the Child Neurology Foundation or for our speakers today, please contact programs at childneurologyfoundation.org. You can also check out our website, sign up for our newsletter to hear about other upcoming webinars or videos that we're having. Thank you so much. We appreciate you all.
Thank you.
Thank you.